This video is about a condition called arthrofibrosis. It's a pity, really, that medical words seem so difficult if you don't have a basic grasp of Latin or Greek. But in fact, what the word means is joint scarring. So arthrofibrosis is an abnormal condition of joints, where they can become locked up because of scar tissue. It's not only the knee joint that may be involved, as the condition can occur in other joints, such as the shoulder or the elbow. But we're going to restrict this particular discussion to arthrofibrosis of the knee. In order to understand what happens in knee arthrofibrosis, it's really helpful to have a grasp of the relevant knee anatomy, because this is all important. You see, when the knee bends and straightens, those tissues involved in the movement have to be able to accommodate to a wide range of motion. The knee can go from being fully extended, or even slightly overextended, to being fully flexed. That total range can be in the region of 140 degrees, and all the tissues in the various planes have to accommodate to that movement. It's not only a matter of the muscles playing out or contracting, but between tissues and the bones there are also slippery pockets called bursae that help to facilitate this movement. The main one is a big pocket about the width of your hand, which is an extension of the actual joint cavity itself up above the kneecap and underneath the quadriceps muscle of the lap. Again, we come across difficult words because that particular pocket is called the suprapatellar pouch. Well, you know what a pouch is, that's easy enough, and suprapatellar just means above the kneecap. So it is the pouch above the kneecap. It can be quite big, but it varies depending on the person. Sometimes it is even split into two parts. If a knee joint ever really swells up with blood or fluid, the fact that it can get so big and balloon-shaped is because of the spacious potential volume of the stretchy suprapatellar pouch. Normally, however, there's very little fluid in it, and a person would not know that it existed at all. Two further important extensions of the main joint cavity are the slippery recesses down the side of the upper tibia or shin bone, very much like those you have inside your cheeks on the outer side of your lower teeth. In the knee, these are called the lateral recesses, and they allow movement of the tissues around that area just as your cheek recesses do. Another region that is important in allowing movement is around the back and sides of the patellar tendon. The patellar tendon is the bit below the kneecap, the tendinous bit that we will discuss a little later because it's very relevant to the whole discussion of arthrofibrosis. Around the back of it and to the sides of it, again, are little slippery pockets that normally have very little fluid in them, but they allow the movement of the kneecap and its tendon in their small but important excursion here as the knee bends and straightens. A final important area is around the back of the knee, the area of the posterior capsule, which also needs to be flexible to allow the knee to straighten into full extension. So these are the all-important bits that normally allow movement, but which seize up if there is arthrofibrosis, preventing the knee from moving and making it stiff. Look now at the model's thumbs in this picture. That is the area where the suprapatellar pouch is, just under the muscle and tendon above the kneecap. In my opinion, this is the most important area, because this is where early arthrofibrosis tends to start. The model's fingers below the kneecap are showing you the area around the patellar tendon, and also behind it, which can be critically important if scar tissue develops here, as we'll discuss later. So what actually is arthrofibrosis all about? Well, firstly, there's usually some kind of trigger, like an injury, very often with bleeding or infection or both inside the knee. Another trigger can be surgery, particularly surgery that affects the kneecap mechanism. Surgery with the use of a tourniquet, complicated by postoperative bleeding inside the knee requiring drains, should be a heads-up for the potential for triggering arthrofibrosis. Total knee replacement surgery is a big culprit. So firstly, there is a trigger. And then the next link in the chain is inflammation inside the lubricating pockets we identified earlier, that creates sticky strands between the walls of these pockets, making it difficult to get the knee moving again. The sticky strands are called adhesions, and bending the knee pulls on the strands and creates pain in the already irritated lining of these areas. Pain inhibits the quads muscle, and the person may also find it hard to straighten the knee. Two pathways now open up for arthrofibrosis. The patient may be reluctant to move the knee and holds it still as much as possible, usually in a slightly bended position. The lack of movement of the tissue planes allows scar cells to migrate into the area, and the adhesions start maturing into proper scar tissue, which does what scar tissue is supposed to do and pulls the walls of the pocket together. Only this is one place where we do not want this to happen. The second pathway for arthrofibrosis involves a physiotherapy department. A physiotherapist who is not arthrofibrosis aware may push the patient to painful extremes and heighten the local inflammatory reaction. A physiotherapist may refer the person to the surgeon for a manipulation under anesthesia. And if this is not done well, there may be further tearing of the adhesions and further bleeding, again aggravating the status quo. What should be offered to the patient is an explanation of the anatomy and the issues. Early gentle movement within the pain-free range. Deep tissue massage of the area above the patella and around the sides of the patellar tendon. The patient should be instructed in performing these patellar mobilization exercises themselves. If a continuous passive motion or CPM machine is available, it should be used several times a day to gently and slowly passively take the knee through the tolerable range of movement. Knee extension should be maintained with passive extension stretches. What happens if the arthrofibrosis pathway is not interrupted? Let's consider firstly the region above the kneecap, the suprapatellar pouch. Let's take an analogy. Think of the pouch as a collapsed balloon with a little bit of lubricant inside. You can slide the two layers easily over one another. Now take another balloon and add some liquid glue inside. There is now much more traction, and it's harder to rub the two layers over one another. As the glue sets, it becomes impossible without tearing the fabric of the balloon. In its normal state, the suprapatellar pouch is lined by a fine layer of cells that secrete a lubricant. Then, boom, injury or surgery, and there is blood in the knee which becomes thicker and sticky as the cells try to remove it. Sticky strands start to form, and it's harder for the two facing surfaces of the pouch to glide against one another. Once these turn into real scar tissue, the adhesions are like strands of cured glue and motion is greatly limited. Similar sticky adhesions might be forming in the gutters at the bottom of the joint cavity to the sides of the upper tibia, restricting tissue motion here also. From the patient's perspective, any attempt to bend the knee is excruciatingly painful. Squatting is almost impossible, and if some squat is managed, then it's very difficult to get up again, because the pain now inhibits the quads muscle. It might be possible to drop into a bath, but getting out again is incredibly difficult and painful. Most patients have never heard of the suprapatellar pouch and cannot understand why they have this acute searing pain when they bend their knee. The pain is out of proportion to the original event. Now let's look at the area around the kneecap or patella. You need to appreciate that the patella is a special bone. It is embedded in the tendon of the quadriceps muscle, which stretches from hip to shin bone or tibia. The patella acts as a fulcrum that increases the efficiency of the quads muscle when it contracts to straighten the leg. There is not normally a lot of movement in the tendon below the patella, but what movement there is very important. When the lubricating pockets and tissue spaces around the patellar tendon develop adhesions, and this matures into scar tissue, the scar tissue contracts and pulls the tissues down, tugging the kneecap with them. A kneecap that is too low like this is called patella infera, and the dynamics of movement are greatly disturbed. The smooth joint cartilage under the patella is also damaged and sets off changes which can result in arthritis here. Every step is extremely painful and the knee can look deformed. The pain and reduced movement in the knee often results in people walking badly, with the knee held in a slightly bent position. And this creates the next set of problems because it allows the capsule at the back of the knee to tighten up, preventing the person from regaining full extension. So now we have a patient whose every leg action is painful, limping with a bended knee, unable to bend it fully, unable to straighten it fully, reluctant to participate in physiotherapy because of pain. They may actually be putting off going for physiotherapy, so that when they arrive at the physiotherapist, the situation is already a challenge to manage. A physiotherapist who may not have experienced this particular problem before may become frustrated at the lack of progress and push the patient harder, aggravating the situation. It's not hard to see a disaster in the making. The harder the therapy is pushed, the more the inflammation, and the more the scar tissue response. Before long, the patient will be referred back to the surgeon, and a classical first line of management is a manipulation under anesthesia. If the surgeon is experienced and the adhesions are not too far matured, then this may restore range of motion. An experienced surgeon will know by feel when things have already gone too far, and is not likely to push the manipulation to the point of actually damaging the internal structures further. An inexperienced surgeon may, however, not fully appreciate the issues and may manipulate too forcefully, and this can tear tissues and cause internal bleeding and increased pain, and the cycle is likely to continue. So my first message here is that patients need to learn about this condition because they are in the best position to ask for help early and even to initiate deep massage, gentle motion and extension stretches. The second message is that the window of early opportunity to turn the situation around is only a few weeks, during which time the adhesions can be relatively easily broken and the inflammatory process reduced. After this time, the scar tissue is too developed to respond to anything but surgical intervention. Surgery takes the form of lysis of adhesions, or anterior interval release, or posterior capsulotomy. Lysis of adhesions is a surgical procedure to release the tissues using a special tool that sort of dissolves them, and that is most appropriate for the suprapatellar pouch. Anterior interval release is the surgery around the patellar tendon, and this is somewhat more demanding. The procedure of posterior capsulotomy means the release of the tissues at the back of the knee surgically by cutting the capsule at the back of the knee to allow the tissues to give again. All of these surgical procedures need to be accompanied by good pain relief, maybe even epidural anesthesia, carried on into the post-operative period. Continuous gentle movement with a CPM machine. A focus on regaining extension, maybe with a special splint worn intermittently, and re-encouraging activity in the quads muscles. My next message is that more clinical people need to understand the critical importance of early and appropriate intervention in patients where there is a likelihood of arthrofibrosis developing. In recent years, the medical literature seems to be paying more attention to arthrofibrosis, which is an excellent sign. Before I end this video, I want to let you all know that there's a special group of people in whom this arthrofibrosis process becomes particularly florid, and the entire space inside the knee joint can become packed with scar tissue, and the internal anatomy completely obscured. These people seem to have a genetic disorder that makes this whole problem very much more difficult to manage. They may need help from special tertiary referral units. But my last message is that there are just not enough surgeons out there willing to build the sort of team of people necessary to take on referrals like this when the process is already established. On the KNEEguru bulletin board, which I manage, it is clear to see that patients are desperate for help all around the world and do not know who to turn to. Perhaps this little video will help to make a difference. Thank you for listening.
Don't forget to like this video and subscribe to our channel. Learn more about your knees at kneeguru.co.uk.